Good morning, everyone. Dr. Dhawan here. I am ready to join. Whenever you guys are ready to let me know, please.
Good morning, sir.
Good morning. Good morning, everyone. Good morning. Take your time and let me know. Okay.
Okay, sir. Sir, we can start the session, sir.
Am I visible? Am I audible?
Yes, sir. Yes, sir.
Good morning, everyone. Dr. RAJIV Dhawan here. And first of all, on 15th August, wish you all happy Independence Day. And so many people being available to study in the morning of 15th August means that You guys are committed to do that, and I'm really, really glad. Uh, and who is presenting the case? Who is presenting the case?
Sir, Netra Lakshmi, 21 batch final year student, sir.
Okay.
Sir.
So, okay. Netra, are you ready? Netra? Yeah. Good morning, Netra. Are you ready? You can't. Please help Netra. He's unable to unmute the phone. Actually, somebody has to unmute the phone and share the screen. In the meantime, I will introduce myself uh, because you should be knowing whom you are interacting. I am RAJIV DHAWAN. I did my post graduation from Lady Hardinge Medical College, Delhi, MS ENT, and then I did my postgraduate training further from All India Institute of Medical Sciences, New Delhi. And I've been into medical practice and medical teaching for last now, you can say, close to 20 years. I passed my master's in 2003. And case presentation is very, very vital because this is a long case, and a lot of times, your examiner would assess you on the basis of long case significantly, because Viva can go into different directions in the long case. And particularly CS1 case is well chosen case that most of the people get the same case in the final Viva. So Netra, are you able to unmute yourself?
Sir, good morning, sir.
Good morning, Netra. Good morning. Happy Independence Day.
Happy Independence Day, sir. Thank you.
Please share your screen.
Yes, sir.
Yeah, take your time.
Okay, sir.
In the meantime, anybody who want to ask anything particularly about anything, any question in your mind, you can always ask in the meantime, after the session also, in between the session also. I'll try to touch upon the more commonly asked questions around tuning fork, because that is one thing, like people are worried about. Some Viva around the management, they go in after you declare the case diagnosis provisionally. But anyone, any particular thing, you can let me know. For ENT, there is no, whatever textbook you are following, Praveen, there is always clinical examination at the back of that book. Follow that. Do not invest separately into a clinical examination book for ENT, because it's a very straightforward examination, to be very honest. It's not like, just go to the last part of the textbook you are following. It should be good enough. Netra, can you do it in the landscape mode, your phone, and remove my picture from there? Just slide out my picture from your screen of your, yes, perfect. Can you do it landscape, twist in the landscape mode? Is
Yes,
possible
sir.
for you?
Yes, sir.
Yeah. Yeah, that should be great. That's wonderful. Netra, please tell me which medical college you are from.
I'm from Madurai Medical College, sir. And I'm currently in my final year.
So your final year is loaded with many subjects now, medicine, surgery, obs-gynae, and ENT ophthalmology in the final year only.
Yes, sir.
So don't worry about that. Actually, I know it's a very voluminous task, but it will keep all these subjects fresh for your NEET PG also. Look at the brighter side. But yes, it is a tougher this thing, but it means that you should be reading more number of hours every day. And Netra, I must tell you, Madurai is very close to my heart that way, because my wife did her fellowship from Arvinda Institute, Madurai. So we have almost Madurai for 2 years. So
Okay, sir.
So can we start team now?
Yes, sir. Yes, sir.
Start.
Sir, patient name Ragini, aged 50 years old. She's a female and she's from Nattam, Madurai, and she's a housewife. She came with chief complaints of right-sided ear discharge for 5 months and decreased hearing in the right ear for 5 months. The patient was apparently normal 5 months back, after which she noticed decreased hearing in the right ear, which was insidious in onset, gradually progressive, but better heard when spoken loudly. There were no aggravating and relieving factors. She had discharge from the right ear for 5 months, which was insidious in onset, gradually progressive. It was intermittent, mucous in consistency, not blood tinged, not foul smelling, and it aggravated on exposure to cold weather or head bath. Whenever water went inside, it aggravated, and there were no relieving factors. There's no history of associated pain, no history of fluctuation in hearing, no history of tinnitus, no history of vertigo, no history of throat pain, no history of upper respiratory tract infection, no history of fever, no history of nausea and vomiting, no history of giddiness, no history of headache, no history of facial weakness, no history of neck rigidity, no history of diplopia, and no history of trauma.
Okay. Mhm.
Past history: patient is a known case of diabetes mellitus and she's under regular medication. She has no history of hypertension, asthma, or any other chronic illness. And patient had similar complaints 1 year back.
Okay. Yeah.
Personal history: she consumes mixed diet. She has normal appetite. Her sleep is adequate. Her bowel and bladder habits are regular.
Mhm.
Family history: she has no significant family history. So, summary: this is a case of a 50 years old female. She's a known case of. Sir, are you able to see my screen, sir?
No, and right now, not earlier it was visible. Just few seconds back. You can share that device screen again.
Okay,
No
sir.
problem. Take your time.
Okay, sir.
Whenever you preferably keep it in landscape mode. Actually,
Okay, sir.
take your time. Yes. Everyone, the speed of presentation which Netra is following is highly appropriate. Do not go too slow, but do not go too fast also. Always remember in medicine, surgery, Viva also, they want you to be presenting at an optimal speed actually, because they do scan a lot many students. So just don't be too slow, but don't be too fast actually. And when examiners are talking to each other, just take a pause at the time, and when they bring their attention back to you, then you start speaking again. Netra, you can share your screen in the meantime.
Yes.
Always make sure that you never use any kind of abbreviation in any subject. Do not say CSOM. Do not say anything like abbreviation. You should be fully presenting like a professional manner. Okay. Just make my.
This is a case of a 50-year-old.
Swipe out my picture. Swipe out my picture. Swipe out my picture.
Okay. Okay, sir. This is a case of a 50 years old female, a known case of diabetes mellitus, presenting with complaints of decreased hearing in the right ear since 5 months and discharge in the right ear since 5 months, with similar complaints 1 year back.
Take a pause here now and give a chance to the examiner to ask any appropriate question. Okay?
Okay.
Because history, there are like 2 points where examiner asks question. One is at the end of the history. Other is when you present the provisional diagnosis. Mostly it's like that. Or in between, he can interject into. Now, Neta, go back to the this thing. Just go back and may I ask you, Netra, that why did you ask the history of pain in this case? You said that negative history for pain. What was the reason of that? Netra, are you there? Netra, are you there? Or okay, in the meantime, I will tell you, otitis media, chronic suppurative otitis media, is a painless disease. Pain would be indicating some issues starting, It may be like simple otitis externa happening because of the discharge coming from middle ear. Number one thing is that. Okay. Yeah. Yeah. We're coming to that. So pain, why pain important? Pain can be indicative of otitis externa as a sequel to the middle ear discharge. Number two, this is a diabetic patient. And diabetic patient, having ear discharge, anybody can tell me which disease we must rule out? Any chronic diabetic patient with ear discharge, which disease would you like to rule out in the setting of this kind of profile? Very good, Prem. Everybody please comment. Malignant otitis externa, also called as necrotizing otitis externa, also called as skull-base osteomyelitis. So 3 diseases are there. Any old diabetic patient with uncontrolled diabetic status with excruciating pain, this more at night also, this is in favor of malignant otitis externa, which is infection of underlying bone of the exonotory canal. It's a very serious infection because there can be multiple cranial paralysis in a patient of malignant otitis externa. And the patient can die also of that. So you should be taking negative history in a diabetic patient of the ear pain very, very carefully. Netra, are you back with me? Netra? Yeah. So second thing is, she
Yes,
asked.
sir, I'm back, sir.
So show me the negative history. Yeah, negative history.
Yes, sir.
Yeah. Swipe out my picture.
Yes,
Swipe
sir.
out. So Netra, when you were not there talking about the pain, why did you ask the pain in this patient? No history of pain?
Extra auditory canal involvement and to
Yeah.
rule out secondary infections. Absence.
Just always say, I want to rule out the otitis externa. I want to rule out mastocytitis because mastocytitis will be a painful disease. Pain will be behind the pinna. And
Okay.
more importantly, Netra, in this case, you are ruling out malignant otitis externa because patient can be having that possibility since patient is diabetic. And whenever patient is diabetic and ear discharge case is being presented, always take the treatment history more properly. Is the patient euglycemic or hyperglycemic, or is the patient taking regular medication or not? It should be a little bit stressed upon more carefully. Is the patient on oral hypoglycemics or patient on insulin therapy along with that? In this case, examiner would be expecting you to speak about the diabetes treatment more detailed to just prove to the examiner that patient is having regular control of blood sugar. You have asked about the fluctuation in hearing actually. Anything in your mind when you asked about that fluctuation in hearing?
So because when the patient is actively discharging, she'll have associated.
Why? Why do you think so? Fluctuation in hearing actually.
Because
no problem. Anybody would like to answer? Yes, it is not assessment. This thing. Everybody, this is a collective way we are studying together in the class. I'm also presenting the case.
She will have better hearing during your discharge, sir, due to round window shielding effect.
Yeah. That's very good, Netra. Round window shielding effect this is the word they want to hear in the Viva. The round window shielding effect means that probably, for example, this is a case with a very short history of 5 months actually. But had it been 5 years actually, there can be ossicular erosion in untreated safe CSM also. First ossicle to erode is incus, particularly lenticular process of incus will go away. Anybody you can tell me, apart from Netra, anybody can switch on your microphone and tell me that why incus is the first bone to get eroded in chronic otitis media?
So because it has minimal blood supply.
Very good, Pragati. It has least blood supply. The reason is there are only 2 muscles in the middle ear. One is tensor tympani muscle, which is for the malleus. Other is stapedius muscle, which is for the stapes. Incus does not have any muscle attached to it, and every muscle brings some blood supply for the bone. Hence, incus has the least blood supply, therefore high chance of erosion in a setting of chronic infection in the middle ear. Wonderful answer, Pragati. And now what happens, Uche? What happens when all ossicles get eroded? Incus goes first, then malleus goes, then stapes head also goes. Only footplate of stapes is left over there. Now what happens? Why nature gave us two windows? Why, nature gave us two windows. Why? Because nature wants to phase difference between two windows, because the sound energy does not travel in one phase. It look at my hand, it has compression and rarefaction phase. When the oval window goes inside, round window comes outside, it's vice versa. This is a phase difference between two windows. Now when look at the natural arrangement of ossicles, the sound energy first hits the oval window, and oval window goes in and round window comes out, and there's a difference of the phase between the two windows. But when the three ossicles are gone, malleus, incus, stapes are gone, now both windows are equally available for the sound energy to be hit at the same fraction of time. Now the movement will be like this. This is not effective stimulation of cochlea. What happens when in this setting of CSOM, some ear discharge comes over there and it covers the round window. The discharge is overlying the round window. It is hiding the round window. There'll be some time difference. There'll be some phase difference between the two windows when the sound energy hitting these two windows. Now, when that discharge is not there, the hearing will be lesser. When the discharge comes there and covers the round window, there is again establishment of the phase difference between two windows. That's why there's fluctuating hearing loss. And this is called, as Netra very rightly pointed out, round window shielding effect. Now, everyone, please comment in the chat box. Could you understand the round window shielding effect? Please tell me. I need to make sure that this 1 hour is useful for your Viva also. Please tell me, did you understand the round window shielding effect? Okay, very good. Everybody, please be involved. Shivani, thank you very much. Okay. So, and just keep a paper with you. Always habit of keeping a diary with you. Keep writing these words. They will be helpful in the final day, in the morning before the examination. Look at a diary and you will be getting some tricky words over there. Wonderful. Thank you, Netra. Netra, why did you ask the history of tinnitus or vertigo in this case? Why tinnitus? Why would you ask tinnitus?
Because we may get tinnitus in secondary infections due to irritation of nerve endings, or if there is any inner ear pathology.
Very good. Yes, tinnitus can be due to exonotory canal problem, middle ear problem, and inner ear problem. So tinnitus can be in wax also. You are right. Tinnitus can be in a perforation also. And tinnitus can be more enhanced than when the inner ear affliction is there. And why would you ask vertigo? Very important Viva question. Everybody note down on the diary. Vertigo or dizziness, why it is being asked?
To rule out labyrinthine pathology.
It's very good. Labyrinth, inner ear, it can be labyrinthitis or it can be labyrinthine fistula in a case of particularly the unsafe CSOM, because in unsafe CSOM, there can be erosion of the outer bony cover of the lateral semicircular canal bulge, and that will be called as labyrinthine fistula. Okay, so very right. When they ask you, why did you ask vertigo? You should always say, sir, we have to rule out either labyrinthitis or labyrinthine fistula. Then they'll ask you that labyrinthine fistula is a fistula of which canal? Answer is lateral semicircular canal, which is also called as horizontal semicircular canal. They'll ask you, why so? Why so? Why only lateral canal? Why not superior canal? The reason is the lateral semicircular canal makes a bulge on the medial wall of the middle ear, which is very much available to be eroded because of the middle ear disease. Okay. Now, you said giddiness also. Netra, would you like to point out any other cause which will be reason behind the giddiness in this case? You said below giddiness, apart from inner ear infection or inner ear fistula. Any other thing coming to your mind? Any other cause?
Sir, if the infection ascends up to the cranial cavity.
Yeah, very good. All of you look at me. The roof of the middle ear is the base of brain. You can say the tegment tympani is the right above that is the brain actually. And I will show you a picture also later on when I share my screen. The thing is that there is a possibility of otogenic brain abscess in a case of CSOM, particularly unsafe CSOM. The otogenic brain abscess most commonly seen in temporal lobe, but second site in otogenic brain abscess is cerebellum. So cerebellar abscesses, which can be occurring as a possible complication of the unsafe CSOM, will have, of course, the gait disturbance, disequilibrium, and giddiness over there. That is the second possibility. Now, Nita, may I ask you, why did you ask history of headache in this case?
Complications of unsafe CSOM, meningitis is there, sir. So to rule out meningitis.
Very important. Yes. Everybody please note it down. They'll ask you why headache has been asked over there. Because ear discharge with headache is a direct clue for an intracranial complication of CSOM. Because otherwise there is no earache, there is no pain behind pinna, there is no headache in a patient of otitis media. Headache means there are multiple possibilities now. As Netra rightly pointed out, there can be meningitis, number one, there can be subdural empyema, there can be otogenic brain abscess, there can be otitic hydrocephalus also. And all these things would have the first symptom as headache. And if you have got right, clinical acumen, you will order the CT scan immediately in that case. Very good. Again, may I ask you, what is in your mind when you ask fever?
Fever, sir. In mastitis, we'll have fever, sir.
Yeah, a very mild fever in mastitis can be there. And then fever, again, can be seen in meningitis. Fever can be seen in sigmoid sinus thrombosis, also called as lateral sinus thrombosis. Right behind the ear will be sigmoid sinus or lateral sinus. So two things which can happen in the brain infection, which are very serious ones, are the otogenic brain abscess and the sigmoid sinus thrombosis. And if you remember, in sigmoid sinus thrombosis, there is a typical spiky fever, and that is called picket fence fever. Picket fence fever is the garden fence-like pattern. After every few hours, this thrombus in the sigmoid sinus releases septic emboli in the blood, and that causes the spike in the fever. So this spiky fever in sigmoid thrombosis is called the picket fence fever. That's why it's important to ask. Now, why do you ask about the throat pain, upper respiratory infection in this case?
Because infection might ascend from through the throat, through the eustachian tube, it might ascend to the middle ear.
Yeah, absolutely. Because if you have a patient who has got, for example, sinusitis along with the CS1, if you do not treat sinusitis first, surgically or medically, and you just operate the ear with laryngoplasty or tympanoplasty, the surgery is bound to fail. Generally, ENT is system of intercommunicating cavities. Please understand, right from nasopharynx you take it to start, and the same tube is continuing the middle ear and the mastoid system also. So if the patient is suffering from any nasal issue, chronic sinusitis or DNS or something like chronic tonsillitis, you have to stage the surgeries. Number one, remove the root cause and then only operate the ear. Otherwise, surgery of the middle ear will be failing in that case. That's the reason behind it. And also, Netra, can you go to the previous page?
Yes, sir.
Previous page. You said that there is discharge is aggravating on exposure to cold weather, head bath, and no relieving factor. In this, one thing should be added: discharge gets aggravated when patient get cold. For example, exposure to cold weather means patient get upper respiratory infection like that. So exposure to means that whenever there is a URI over there, there will be increase in ear discharge. This is more in favor of the safe CSM. Unsafe CSM does not have this kind of change in the volume of discharge along with the infection in the nasal cavity. So whenever you say this, that discharge increases whenever patient gets upper respiratory infection or common cold, it is like helping you diagnose the case towards the tubertympanic CSM. Okay. Now, Just go down, down. Yes. Next slide. Yes. Yeah. Next one. Next one. Yes. Next one. Yes. Yes. Facial weakness is very, very important. Ear is married to facial nerve. You know, facial nerve travels through the, the inner ear and the middle ear, and it is having a, like very long journey to the ear. So all ear infections can lead to, facial nerve palsy. You can ask me, Rajiv, facial nerve palsy can be only seen in unsafe CSM because unsafe CSM has got the erosion of the bone. No. Facial palsy can occur in even ASM also because there is a congenital dehiscence of the facial nerve bony canal in many people actually. Congenital dehiscence of the facial nerve bony canal will make the nerve exposed in the middle ear cavity. Even an episode of acute otitis media or safe CSM can lead to edema of the nerve and facial nerve. Palsy can start over there. Now, anybody can tell me, Netra, if you want to try it, first of all, which segment of the facial nerve canal has got highest incidence of the congenital dehiscence or natural dehiscence? Which segment of the facial nerve canal has highest incidence of natural dehiscence of the facial nerve bony canal?
I don't remember, sir.
Prem, yes, very good. Prem. Everybody answer. Everybody. The answer is horizontal segment, also called as tympanic segment of the facial nerve canal, which lies on the medial wall of middle ear. Horizontal segment or tympanic segment is one and same thing that lies on the medial wall of the middle ear, and it is between the first genu and the second genu. Okay. So Netra very politely said, sir, I do not remember. This is the way to speak in the exam also. Do not get nervous when you do not know anything. You should not really start beating around the bush also. Examiners know certain things you will not be knowing. I repeat, examiners know certain things you will not be knowing. It's absolutely okay. Do not get nervous in the examination because it's the case presentation means presenting the case like a doctor with the stability, with the clarity, and with very much like synchronized kind of activity that is judged by the examiner. So like Nitra said, sir, I do not remember. Politely say, sir, it's not coming to my mind at this moment. It's okay. Fine. Now, Netra has asked about irritability, neck rigidity. I think everybody knows that it is because of meningitis. And now visual defects or diplopia. Everybody, Netra, would you like to tell me why diplopia has been asked in this case?
Yes, sir. Because if the lateral rectus nerve is involved, this cranial nerve 6, we'll have diplopia.
What is the name of that entity which you're thinking about?
Cavernous sinus involvement.
Okay. This will be petrositis or Grady-Nigo syndrome. Petrositis or Grady-Nigo syndrome. This is due to the infection traveling from the middle ear cavity to the petrous apex area. And petrous apex is closely related to two nerves, trigeminal nerve and the abducens nerve. And in that petrositis, we get a syndrome called Grady-Nigo syndrome. Grady-Nigo syndrome. Yes, Grady-Nigo syndrome, the mnemonic is very beautiful. G-E-R-D, your Viva question. Petrositis, also called Grady-Nigo syndrome, Grady-Nigo, G-R-A-D-I-N-E-G-O, Grady-Nigo syndrome, G-E-R-D, G for Grady-Nigo syndrome, E for ear discharge, R for retroorbital pain due to fifth nerve involvement, and diplopia due to sixth nerve involvement. So, ear discharge is the starting point of this problem. The middle ear discharge got spread out to the petrous apex area. That's why we get the Grady-Nigo syndrome over there. No history of trauma. That's absolutely all right. Summary is okay. Diabetes mellitus. And I would just request you to, whenever you have diabetes mellitus, please go into more detail of the treatment history. That is appropriate. Now,
okay.
Everyone, you're invited now for asking any question coming to your mind. And please tell me if this session is useful for you, because that's very, very important. On a Independence Day morning, you're studying. It has to be of value to you. Please scribble in the chat box. Or you can switch on your mic also, if it's allowed. I don't know whether setting allows you now. Please tell me in the chat box, yes. Okay. Any questions, Buddha? Any questions? Any question, Prem, Sanya? Yes. Okay. So can we proceed with the further one? Okay, fine. Perfect. So I think we can go to the next step. Yes. Proceed further. Yeah, we did this thing also. The personal history is fine. And Nitra, one thing I would like to tell you, ear discharge, which is more at night, ear discharge, ear pain, which is more at night, ear pain, nocturnal ear pain, in the backdrop of ear discharge. Nocturnal ear pain in the backdrop of ear discharge is generally seen in two issues. Number one is, of course, malignant otitis externa, which is seen in diabetic patient. Number two is malignancy of the ear. In the malignancy of the external canal, particularly, the pain is there at night more commonly. And why ear discharge, sir, in malignancy? Because chronic ear discharge becomes a predisposing factor for the malignancy of the external canal. Okay, fine. Now,
Yes, sir.
I'll explain once again when I get the access to my iPad. Don't worry about that. I'll note it down. Yes. Next one. Next, please. Family history is not significant in this case. Very good. Next one. So this is a summary of your case. Right now, everybody, can you read the summary again, Nitra?
This is a case of a 50 years old female, a known case of diabetes mellitus, presenting with complaints of decreased hearing in the right ear for 5 months and discharge in the right ear for 5 months with similar complaints 1 year back.
Okay, fine. So this is the second episode actually, but this similar complaint came in the history, or when you explain on the top, go up. Patient had similar episode 1 year back. Did we write it down? Or maybe I missed it.
Yes, in past history I wrote, sir.
No, go up. Actually, go up in the 5 months history in the beginning. In the beginning, when you saw that, okay.
No, that I did not write, sir.
I think you know why when we say 5-month history, it is better to say at this moment the patient had similar episode 1 year back as well, because then the examiner gets to an idea. Oh, this is a chronic problem going on for the last 1 year, and in between the ear was dry, and now ear discharging again. So at this point also, it's better to write that statement again. Okay.
Okay, sir.
Go next now. So general physics examination, generally when you come at this level, just pause, take a pause in ENT, in particularly GP. So general physics examination, just take a pause, because most of the time examiner will tell you anything significant in this, then you can save your time over there. They say, sir, anything significant you can tell over there. Otherwise, you can go. So it was normal. So. And generally in ENT Viva, they don't go into the GP, to be very honest with you. Okay, until an examiner is very, very medicine oriented. So it's okay. Anything positive in GP? Anything positive?
No, sir.
Okay. Now. Okay, just we are seeing it as she's going down. Very good, everybody. Let's focus on the ENT part now. Systemic examination.
Nothing, sir. Everything normal, sir.
In systemic examination, CNS is very, very important, because when you say no focal neurological deficit, it means the facial nerve has been assessed properly. And please do check facial nerve, because the examiner might ask you, how did you do the examination of the facial nerve features actually? So you should have done that, and you should be remembering at that moment also facial nerve examination, and other kind of particular eye movement should be tested in the ear discharge patient. That is going to be important, because as I told you, 5th and 6th nerve are very much close to Peter's apex areas. So cranial examination has got a significance, and in lot of disorders of ear, there can be the 9th, 10th, 11th nerve palsy also. For example, in jugular foramen area, in a tumor called glomus jugulae, because jugular foramen is the same place from 9th, 10th, 11th now are coming out, and the tumor occurs in the same area. There can be 9th, 10th, 11th, 12th, 11th palsy also. So there is always the scope of viva in the cranial nerve examination. So when you say CNS, you please say all cranial nerves examined and found to be normal. Rather than saying no focal neurological deficit, the more appropriate statement in ear presentation will be all cranial nerves examined and found to be normal. That will be more. You know, olfactory nerve is very, very close to our heart actually. And a lot of people can have anosmia or hyposmia in conjunction with ear disease as well, actually. Okay. So this particular point should be highlighted. And there's no harm in mentioning cranial examination. Facial nerve examined, found normal. All other cranial examined, found normal. This would be appropriate. Netra, is it okay?
Yes, sir, sure.
Please say like that: cranial examination, facial examined, found normal. All other
Yes.
examined, found normal.
Yes, sir.
Next one.
Now coming to the local examination. Right ear, pre-auricular region normal, pinna normal, post-auricular region normal, external auditory canal normal, mucoid secretion seen in the external auditory canal, tympanic membrane, it's pearly white in color, and there's a central oval perforation seen approximately 2 cross 2 millimeter in size.
Mhm.
Mastoid region is normal. The facial nerve is normal. And
May I ask you, Netra, at this point that when you say mucoid ear discharge, mucoid,
yes, sir.
you know, what are the various causes of ear discharge in your mind?
There is serous discharge. Then
No, what causes? What are the possible causes like that of ear discharge?
almost all middle ear pathologies have mucoid discharge, sir, because middle ear has goblet cells.
Yeah. So mucoid discharge, yes, but like purulent discharge. Yes.
Purulent discharge in external auditory canal pathology will have frank purulent discharge.
There will be in the external auditory canal or external, we can have the purulent discharge. Otherwise, it will be mucopurulent. Whenever the mucoid discharge along with the pus, there will be mucoid element will be indicating middle ear infection. As Netra very rightly pointed out, that there will be goblet cell in the middle ear mucosa only. Yeah. Tympanic membrane is pearly white in color. Better word is pearly gray. Everybody, please, there is a lot of debate on this color. Please use the word pearly gray because it's actually not white. According to Scott Brown and according to the Cummings also, pearly gray is the appropriate word for tympanic membrane normal color. And when we say central perforation, they would ask you, what do you understand by central perforation? Netra?
Perforation seen in the pars tensa region not involving the annulus of rim.
Yes, very good. Central perforation, as rightly pointed by Netra, it is in the pars tensa, lower part of tympanic membrane, and there should be some margin left all around the perforation. It should not be touching the annulus. What is annulus? Annulus is the peripheral thickened edge of tympanic membrane, which fits into tympanic sulcus of the temporal bone. So it should not be touching the annulus area. There should be some intact margin left all around the perforation. That is meant by the central perforation. The other perforation, when the margin is absent, is called marginal perforation. And that is more in favor of unsafe or aticoenteral CSO. Now, go down a bit. Yes. Anybody who wants to ask any question up to this level? Anybody? In the upper slide, Nitra, upper slide.
Yes.
Anybody who wants to ask anything? Pinna is normal. Post-auricular region is normal. We've done external auditory canal. Tympanic membrane, she's commenting normal. Middle ear, of course, not visible in the other side. So mastoid normal. Everybody, please tell on the affected side mastoid. Mastoid tenderness is negative. Please note it down, everybody. On the affected side, at least on the right side, you must palpate the mastoid area for any tenderness. And when you say mastoid normal, please say mastoid on inspection. There is no edema in the mastoid. There is no, congestion of the skin of the mastoid area.
Actually, I had written that, sir, in the right side region also, but it is
That
not.
is not.
Yes, sir.
So all of you, please understand that, comment on this thing that the mastoid should be explained more in detail on the affected side at least. Other side, you can use the word the normal, but mastoid is inspection and palpation. Inspection is the redness or edema on the mastoid. Anybody who can tell me whenever there's mastoiditis and there's edema on the mastoid, what is the name of that sign? In mastoiditis, whenever there's edema on the mastoid, on inspection, what is the name of that sign, everybody? Anybody who wants to ask? No, it's not lighthouse sign, bache. It is called ironing sign. Ironing. Lighthouse sign is the discharge flowing very fast over there. Ironing sign means the mastoid is, so the skin of the mastoid covering the mastoid has become red edematous. It is smooth red and shiny, and that is called the ironing sign. And they can ask you, which is the first sign of mastoiditis? It is the ironing sign. Then come the tenderness. Okay, tenderness. Mastoid tenderness is very, very important to be mentioned. And mastoid tenderness is first checked on the antrum. What is antrum? Antrum is the largest and the most constant mastoid air cells. This is mastoid. How would you know where is the antrum? Whenever you are, all of it, please look at your pinna. The upper part of the concha of the pinna is called cymba conchae. Cymba conchae is overlying the mastoid antrum. So when you put your finger in the upper part of concha, this cymba conchae, and you check in this area, and you're actually pressing the bone covering the mastoid antrum. So mastoid tenderness should be checked at 3 areas. One is over the antrum, other is the posterior border of the mastoid, third is the tip of the mastoid also. So the mastoid tenderness should be told very clearly, because that is what they would like to hear. Okay. Are you there, Nitra? Okay. So guys, I'll explain the meantime Nitra is joining. That mastoid inspection, the first sign is ironing sign. The second is tenderness. Third is discharge is flowing like a river, because mastoid air cells are making too much of pus. The discharge is flowing like a river. And whenever you see that discharge with the help of otoscope, can you allow me to share my screen in the meantime? Can of iPad? My iPad is, I think it will be the name of the iPad only. Is it iPad 3? Can you allow me to share my screen as well? I think I can share my screen. Yes. Okay. No, I think I have to be allowed actually. Anyway, I was telling that the discharge flowing like a river. So when you see the discharge with the help of otoscope, this is otoscope. Otoscope is the light over there. When this light spot fall on the pus, which is moving like a jerky movement, the light spot also keep moving, and that is called the lighthouse sign. Because the lighthouse sign means the lighthouse sign means, I just want to, somebody, if you can see, allow my iPad, the screen to be shared. Once again. I think only one person is host right now. There is one my iPad also. Maybe I'll join again from my iPad. You get to know. Okay. The lighthouse sign, and then finally, when you clear the discharge with the cotton or the suction, the discharge fills immediately again, and that is called reservoir sign. So, what are the signs to be remembered for mastoiditis? Number one, the edema on the mastoid is called ironing sign. The discharge flowing like jerky movement, that gives the lighthouse sign. Discharge fills immediately again after cleaning, that called reservoir sign. And of course, tenderness should be checked at 3 places on the mastoid: over the antrum, that is in the Simba conche area of the pinna, posterior border of the mastoid, and number 3, the tip of the mastoid, that should be separately mentioned over there. Netra, are you back with us?
Yes, sir. Sorry for the inconvenience.
It's okay. That's okay. Yeah, take your time. In the meantime, I'll tell you that in mastoiditis, whenever you have a, they will ask you about, I think Netra is back. Let us hear.
Excuse me, sir, just a minute. I think you'll be able to share your screen, sir. There's an option below, share.
No, actually, my iPad is there. I think I'll come out of the iPad once and again join it, and
Okay.
then you'll get to know that which one I have joined now. I'm leaving the meeting from iPad. I'm joining from the iPad one more time, so to get an idea that this one I am joining. Join meeting. Please see which device just joined actually. This device, iPad. One second, I'll just. Yes. Yeah. So this device, if you make it later on, host, I'll be okay. Don't let her finish the case first. I'll come to the screen later on.
Sure, sir.
Nita, please continue. Remove my slide out my picture from the screen. Yes, thank you. Please continue now. Yeah. Nita, are you there?
Hello?
Yes. Yeah. Yes.
Yes. Sir, right ear Rinne's test, bone conduction better than air conduction, sir. So Rinne's test negative.
Okay.
Beppel's test localized to the right side.
Okay.
In left ear, air conduction is better than bone conduction.
Okay. So in left ear, the Rene is positive, and in the right ear, affected ear, the Rene will be negative in this case. And Netra, Rene is comparison of ear conduction and bone conduction. May I ask you, Netra, that
Yes.
which tuning fork are you carrying with you on the exam day? That's a tuning fork I'm carrying today. Which tuning fork you are carrying on the exam day? What is the frequency?
256 hertz.
There are 3 tuning forks which we carry in the postgraduate Viva: 256, 512, and 1024 hertz. For the undergrad Viva, which is your Viva, you should carry 512 hertz. Everybody, please note down. You must be carrying the 512 hertz tuning fork in your lab coat on the exam day when you go for the presentation of the long case. Now, they'll ask you, why did you choose 512 hertz only? Nitra, why not 256 is my that favorite as 512? 512 is not my lucky number of ENT people. 512. Why did I not use the 128 hertz? Yes. 2 things to be told. Please note it down. Why 512 hertz is more appropriate for the basic examination of tuning fork? Number 1, it has long decay time. It has long decay time means it keeps vibrating. Please see, when you hit it over here, it is vibrating for a very long time. It gives you time to test the air conduction and bone conduction actually. 128 hertz others will be having less vibration time.
Yeah.
So number 1 answer is it has a long decay time. Number 2, 512 produces less vibrations. 128 hertz tuning fork is for medicine people, and that is going to check the vibration sense. And 128 hertz is more appropriate for the the vibration sense for the neurological examination, but 512 hertz does not more of vibration. So that's the correct. Now, okay. Yes. Now, Nitra, can you tell me on the basis of Rene test, what is your interpretation? It is conductive hearing loss or sensitive hearing loss?
In the right ear, it's conductive hearing loss, sir.
So in normal people, Rene is positive, air conduction better than bone conduction. And in conductive hearing loss, of course, the bone conduction is better than air conduction. Guys, look at me, everybody. It's a comparison of air conduction and bone. We ask the patient which one is louder. The two methods of doing Rene. More commonly used is loudness comparison. The air conduction loud or bone conduction loud. Normal natural way of hearing is air conduction, and the bone conduction, when you keep the tuning for the mastoid, bone conduction directly transmit the sound energy to cochlea. Bone conduction, bone conduction is direct transmission of sound energy to the cochlea. So look at me, everybody. In normal people, air conduction is better than bone conduction. If you have a wax in the ear, if you have an occlusion of the canal by wax collection, now wax in the EAC will be causing conductive hearing loss. Can you imagine? There's too much of wax in my ear. Can I hear the air conduction properly? No. Air conduction will not be proper. It will be decreased. But can I hear the bone conduction properly in wax condition? Yes. Why? Because in conductive hearing loss, cochlea is absolutely normal, and bone conduction directly reaches cochlea via bone. So in wax condition, which is the classical case of conductive hearing loss, air conduction will be less, but bone conduction will be normal. So in any conductive hearing loss, bone conduction is better than air conduction. It is called a Rene negative. Rene negative. Okay. And in SNHL, in sensory neural hearing loss, Rene will be positive. But again, why? Look at me. In normal people, air conduction is better than bone conduction. Agreed. That is Rene positive. But in SNHL also, Rene is again positive. Again, air conduction is better than bone conduction. Why? In SNHL, what is not working properly? Cochlea. Sensory neural hearing loss means cochlea is working less than normal. Cochlea is working, but less than normal. You go through air conduction or you go through bone conduction, ultimately you go to cochlea only. I repeat, in SNHL, cochlea is working less than normal. You go through air conduction or you go through bone conduction, ultimately you enter the cochlea only. So if cochlea is not working properly, both air conduction and bone conduction will be equally affected. They will equally come down. Look at me. This right band hand is air conduction, this is bone conduction. In normal people, AC is better than BC. The air conduction is better than bone conduction. In SNHL, both AC, BC come down equally. But if they both come down equally, they still maintain the original difference they had. Original difference was AC better than BC. May I say it again? In normal people, air conduction is better than bone conduction. In SNHL, cochlea is not working properly. You go through air conduction or you go through bone conduction, ultimately go to cochlea only. So if cochlea is not working normally, both AC, BC will be equally affected. When they equally come down, they still maintain the original difference they had, which was AC better than BC. So in normal people also, and in SNHL also, air conduction is better than bone conduction. It is called Rene positive. And I want everyone to comment on this. Could you understand why Rene is positive in normal and SNHL both? Are you able to understand this one? Everybody please comment in the chat box. Could you understand why in SNHL this Rene is going to be positive again? Because both AC and BC are equally affected. Please come in the chat box and tell me, could you understand this? Okay, perfect. Perfect. Okay. Now, guys, then they ask you this question, the quantification of hearing loss on the basis of Rene. Netra, do you have an idea? Can we assess that how much conductive hearing loss is there on the basis of 256, 512, 1024 Hertz Rene testing? This is the nature of hearing loss, conductive versus SNHL. Second is quantification of conductive hearing loss. Any idea, Netra?
No, sir.
Let me tell everybody, note down. If I can get okay, I will save this question when I get the screen sharing with me. I'll write down for you. Don't worry about that. Okay, Netra, you can go further. Yes. So Weber test is lateral to the right side. Everybody, Weber test lateral to the right side. Netra, how we do the Weber test?
So we have to place the tuning fork in the middle of the glabella region in the forehead. We have to
Okay.
place it.
That's all.
And then we have to ask the patient which side vibrations are felt better, the right or left.
Don't use the word vibration, sound. In
Sound.
ENT, we don't use the word vibration. We are checking the sound sensation. Okay. So
Okay.
you're right. Keep the tuning fork. Weber test is always done with the 512 hertz, and we vibrate tuning fork and we keep the center of the forehead over here, and we ask the patient where the sound is heard. And in normal people, the Weber sound is heard in the center of the forehead. In conductive hearing loss, the Weber sound is heard in the poor ear. Look at Netra screen over there. Weber is localized to the right side. In conductive hearing loss, the Weber will be heard in the poor ear. Poor ear means ear with the hearing loss. In this patient, right is the poor ear. Why? Patient is having right side hearing loss. So right is the poor ear, left is the better ear. In conductive hearing loss, the Weber sound is lateral to the poor ear. In SNHL, the Weber sound is lateral to the better ear. Everybody demonstrate on yourself. Everyone do it with me. All of you press your tragus. All of you press your tragus right now. Everybody, one side tragus, press it. And everyone must do it. Everyone must do it. Press your tragus and close your ear completely. Close your external auditory canal completely. Now this ear is the poor ear. This ear is suffering from conductive hearing loss. By pressing the tragus, you have stopped the conduction of sound energy to your external auditory canal. You have closed your external auditory canal. So this ear is poor ear suffering from conductive hearing loss. Everyone do with me. Right now, press your tragus and say louder. Say 1, 2, 3. Say by pressing tragus of one side, say 1, 2, 3. Do it. Say 1, 2, 3. One more time. By press your tragus and say 1, 2, 3. 1, 2, 3. Did you notice one thing? You are hearing your own sound on this side. You are hearing your own sound on this side. This ear is poor ear, suffering from conductive hearing loss, and your own sound is heard on this side. This will help you to recall in the exam that in conductive hearing loss, Weber is heard in the poor ear. One more time, do press your tragus and say 1, 2, 3, and tell me, could you understand this in the chat box? Tell me, could you understand this? Could you feel this? That when you press your tragus, you produce conductive hearing loss on yourself. This is a poor ear, and you could actually feel your own sound, hear your own sound on this side. It will help us recall in the exam that in conductive hearing loss, Weber's sound is lateralized to the poor ear. Please tell me, could you understand? Could you relate to this? Okay, could you relate to this? Will it help you for the exam viva? I understand you have got surgery viva, medicine viva. I want to make your life easier for ENT viva at least to some extent. Okay, it should help you on the exam day. Okay, wonderful. Proceed further.
Yes, sir.
Yes, Netra?
Nose examination, everything is normal, sir. External nasal framework, ALA normal.
Here at this moment, examiner will be very much look at your nasal examination. Please say no nasal discharge seen on endarhinoscopy. Septum in midline, turbinate, no hypertrophy, no nasal discharge seen, because purulent nasal discharge will be indicative of sinusitis element. And if it is sinusitis with chronic otitis media, we have to stage the surgery into two. Number one, treatment of sinusitis. Then only we go for the treatment of the perforation over there. Okay, fine. So discharge should be mentioned in a negative way very clearly over here. Okay, perfect. Next. In the tuning fork, please do not miss the absolute bone conduction testing. You did Rinne test, you said the Weber test. The third test will be absolute bone conduction. Okay, ABC test. Because they would ask you in Viva. If your Viva is going good, they will ask you tuning fork question and all that. And we'll discuss in a while when I come on the screen. Okay, fine. No problem. But ABC, absolute bone conduction. Everybody, let's summarize now tuning fork test. Rene test is comparison of air conduction, bone conduction. Which one is better? This is better or this is better? AC or BC. In normal people, Rene positive. In SNHL, also positive, but in conductive loss, Rene negative. Weber test is keep the telephone in the center of the forehead, and which side sound is heard. If sound is heard in the poor ear, it's conductive hearing loss. And if sound is heard in the better ear, it's SNHL. Third is ABC test. Absolute bone conduction is when you close your EAC and you keep it uniform on the mastoid area, and when patients stop hearing the bone conduction sound, you test on your own ear. In absolute bone conduction, patient bone conduction level is matched with the examiner bone conduction level. So we always say that equal to examiner. ABC test is equal to examiner. In conductive hearing loss, in normal people, it's equal to examiner. But in SNHL, look at me, bone conduction directly goes to cochlea. In bone conduction directly goes to cochlea. In SNHL, the bone conduction, ABC test is absolute bone conduction will be less than examiner. Less than examiner. Why? In this is patient. His cochlea is not working properly. He will stop hearing this sound very early. But when you check as a doctor on yourself, you're still hearing that. Because in patient, cochlea was not working normally. Bone conduction was, that's why, less in the patient as compared to examiner. So in normal people, in conductive hearing loss, ABC is equal to examiner, but in SNHL, ABC is less than examiner. Now, next one. Please continue, Nitra.
Oropharynx normal, sir. Then provisional.
So is normal. Netra, just go up. Go up.
Yes.
Go up a little bit, please. When you're saying this, actually, the core spatula test and all that, please, you should have done it preferably. Like at least do once, because you should be knowing what they're saying. Cotton wool test, core spatula test, they would want. Next one. Next one is. Did you mention about a tonsillar region? Oropharynx normal is perfectly
Yes.
all right.
Okay,
Next
sir.
one.
So provisional diagnosis, it is a case of right-sided chronic suppurative otitis media of active tubotympanic type with central perforation and no complications.
Perfectly summarized. Like this is the way to be. No complication, and there is a case of the tubotympanic CSM, not squamous type, because there is no false malignant discharge. False malignant discharge would have been more favor of unsafe CSM. One thing we should always mention in this case is no polyp seen actually. In the ear examination, the middle ear examination, or the otoscope examination, please do negative mention of no polyp seen, because polyp can be seen in safe and unsafe CSM both. But yes, there is difference in the appearance of the polyp of the safe versus unsafe CSM. The middle ear mucosa, if it is polypoidal in safe CSM, that's more of a pale kind of polyp, but the polyp of the unsafe CSM will be more reddish. Okay, fine. Now, what is the treatment plan in your mind for this patient? How would you proceed with the management of this patient?
We have to think the active discharge, sir. So we have to give antibiotics, local drops. We have to put.
It is active discharge, so you have to control the infection. Yes. Number one, you're saying that topical antibiotic ear drops, oral toilet, clean the OPD, remove the discharge, and do not advise systemic antibiotics for these safe CSM. There's no need until there's a complication. We don't advise that. So once the active discharge is dry, what is the management then next?
Then we have to cover the central perforation, sir.
Yeah.
For that, we have to do tympanoplasty.
Always say that I will do the pure tone audiometry. I'll get the pure tone audiometry done first, because in any ear surgery, you should have the pre-operative assessment of the hearing for multiple reasons. They'll ask you in the Viva also, why you got the pure tone audiometry done. Number one, the nature of hearing loss. Number two is the quantification of hearing loss. Number three, to compare the pre-operative and post-operative audiogram also, because after the surgery, expecting the improvement in hearing. Number four, for medico-legal purposes as well. So I repeat, number one is the whether there is a hearing loss or not. Then nature or type of hearing loss will be established on audiometry. The third will be the quantification, how much hearing loss is there. Fourth is possibility of preoperative, postoperative comparison of after surgery. Fifth is medico-legal purposes also. Am I clear, the team?
Yes, sir.
Total audiometry is very wide. We do not generally go for oral swab patient of CSOM until and unless it's a non-responding ear, like it is non-drying ear. You tried a lot of ear drop like ofloxacin or something like that, chloramphenicol, but it is a non-discharging ear. In that case, we have to go for oral swab for culture sensitivity and give appropriate antibiotic therapy for that. Otherwise, it's a reserve investigation, not as a primary investigation we use. Or do not say oral swab for culture sensitivity just as a primary investigation. If you want to say it out, that I will try the antibiotic ear drops first of all to make the ear dry. And if you ask you what the investigation in your mind, so you can say Puritan audiometry and oral swab for the non-drying ear will be required, and that is sufficient. In the Viva, never oversay anything in one sentence only. In theory, you show off. In Viva, you never show off. The rule is, in theory, write legibly. Legibly means that you should be having clarity in your presentation because you have to write a lot of things. You know, I remember my college days. Remember when I used to really wonder that I wrote so much, I got only 2.5 marks out of 5. But some of the students, particularly girls, will get a lot of marks. Same content, because girls are more disciplined, more organized in their presentation also. They will use the color markers and the underline the things and all that. The same content, when the boys write, we get 2.5 marks only. And some people get 4.5 marks also. So, and the boys only go with the blue pen only. Only blue pen is there. No red pen, no green pen, nothing. So please, in the Viva, please do not show off. In theory, you have to show off because they should be finding your content very easily. Otherwise, they get like pissed off. They give you basic marks and run away. In Viva, just say appropriate, not less, not too much also. Okay, fine. Now, so treatment of choice will be surgery in this case. It's a permanent perforation. Dr. Netra, which surgery is in your mind actually?
I have to do tympanoplasty, sir. That is only if the tympanic membrane is perforated, I'll do meningeoplasty. If there is ossicular involvement, I'll go for tympanoplasty.
Very good. So basic surgery is laryngoplasty. And any laryngoplasty we do, we always do the ossicular inspection also. Whenever you do the ossicular inspection and all ossicle found normal, and then you do the laryngoplasty, that is called the Woolstein type 1 tympanoplasty. In any laryngoplasty, it is imperative that you should be inspecting the continuity or integrity of the ossicles. Actually, it is 2-minute, 3-minute extra job for us. You have to just examine under microscope every ossicle to be having the full like structure present over there, and they should be in continuity with each other. Ossicle continuity should also be there, because sometimes there will be small deficiency over there and incus and stapes are not touching each other. That's also a problem, because the first ossicle to be eroded is incus, and the erosion starts from lenticular process of incus. There can be erosion of the incutostapedial joint, and there should be clear-cut mention in your surgical notes also, all ossicle found to be normal in the structure and in continuity. So if you do the laryngoplasty plus ossicular inspection and all ossicles found normal, and you put the graft over there, it is called the type 1 Woolstein tympanoplasty. The type 2 will be what? Netra, type 2? Woolstein type 2 is what?
It is meningo incudopexy, sir. It is, you have to place the graft over incus.
Very good. In type 2, malleus absent, eroded, and the TM graft is placed in contact with the incus. What is type 3? Everybody, type 3 is important by question. What is type 3?
Columnar tympanoplasty.
Very good. Type 3, INSTT question. So, tympanoplasty type 5. The type 3 tympanoplasty means malleus, incus both eroded, only stapes left over there, and the TM graft is placed in contact with stapes. It is called laryngostapediopexy or columellar tympanoplasty, as Netra rightly said. So in type 1, all ossicle found normal, you put the graft on the tympanic membrane perforation. Type 2, malleus found eroded, you put the graft in contact with the incus. In type 3, malleus, incus both eroded, you put the graft in contact with stapes. It is called columella tibuloplasty or type 3 tibuloplasty. Type 4, Netra, what is type 4?
You have to put the graft over the round window, sir.
Very
Cava.
good. Very good. Very good. Yeah, yeah. What was the word that? What is that?
Cava minor.
So this is same as round window shielding actually. If you rightly pointed out, all ossicle were eroded, malleus eroded, incus eroded, stapes head eroded, only foot plate is left over there. So both window turned equal. So as Netra rightly pointed out, if we put the graft of tympanic membrane perforation in such a way that it covers the round window, but it leaves the oval window exposed to the outside world, there'll be phase difference between two windows. And this is again example of round window shielding effect or cavum. Okay. You can do the reverse also. You can do the reverse also. You can cover the stapes area. You can cover the oval window with the graft also. And you can leave the round window exposed as well. That's also acceptable. But generally we do what? We cover the round window with the graft and keep the oval window exposed actually. Okay. Because we do not want the sound energy to hit both window at the same time. The type 4 tibuloplasty will ensure what? Phase difference between two windows. This is the class what they want to hear in 5 also. Lastly, type 5 will be what? Fenestration operation, which was being done earlier for the surgical management for otosclerosis. But it is an obsolete procedure nowadays. So type 5 is fenestration. Let's have a quick revision of 5 tibuloplasty. Type 1, all ossicle found normal. Type 2, malleus eroded, TM graft touching the incus. Type 3, malleus incus eroded, TM graft touching the stapes. Type 3 tibuloplasty is important. It's called columella tibuloplasty. Type 4, malleus incus stapes head eroded. We put the graft in such a way it covers the round window and keep the oval window exposed to outside world. This is done to maintain the phase difference between two windows. In type 5, fenestration operation is an obsolete procedure nowadays. Okay. They might ask at the end, do you know any new devices in the middle ear implants which are being used nowadays? Yes. Any, Netra, do you have idea? This is Wolstein classification. Yes, it's a good class. But now it is the ready-made ossicles in the market.
Torp.
Yes, very good. ORP. What are ORP? Ossicular replacement prosthesis. They are made of titanium or Teflon. ORP are of two types, PORC and TORP. Partial replacement or total replacement. In I minus S plus situation, we see M minus I minus S plus mean malleus incus eroded, stapes still present. We put the graft, we put the PORP over there. PORP partial replacement will be used for M minus I minus S plus situation. Total will be used for M minus I minus stapes head minus situation. When stapes is still present, we use the partial replacement. PORP. When stapes is also eroded, we use the replacement TORP, total ossicular replacement processes. Right? Netra, could you understand that?
Yes, sir.
Okay. Anyone, any question at this moment? We'll 10 more minutes to go. We'll then finish by 30. I know you'll have breakfast also probably. Any question till now, Bache? Any, please just scribble it. And then can someone allow me to use my screen of iPad, if possible? The iPad screen.
Sir, can you please check if there's a toolbar down there, sir? There's an option to share screen.
Yeah, now it is coming. Yes, I think it's coming now, I guess. Yeah, thank you. In the meantime, I would want you to ask questions. Please ask me. Switch on your mics. This session is for you. No formality here. You can ask me any question if you want to. Anybody, please switch on your mic and please tell me any question. Otherwise, Rene test one Viva question is, Rene is done with 256, 512 and 1024 Hertz. Okay. Now, if the Rene is negative with 256 and positive with 512 and 1024, there's a very minimal level of 15 to 30 decibel conductive hearing loss. Okay, 15 to 30 decibel conductive hearing loss. Conductive hearing loss or AB gap. Okay, but if RINE is negative with 256,512 and positive 1024, it is 30 to 45 decibel of conductive hearing loss. It's very commonly asked question in the Viva also. Okay, fine. Now, everyone, please see. But if RINE is negative with all three of them, it's a significant hearing loss, 45 to 60 decibel conductive hearing loss. This is a very famous NEET PG question also. Everybody, please take a screenshot of this and share with your group also. That quantification of hearing loss as per RINE will be asked in Viva sometime. If RINE is negative 256, but positive 512, 1024, it's 15 to 30 decibel of conductive hearing loss or AB gap. If RINE is negative with 256 and 512 and positive with 1024, it's moderate conductive hearing loss 30 to 45. And if RINE is actually negative with all three, it is 45 to 60 decibel of conductive hearing loss. Okay, so this one, is important. Okay, fine. Now, somebody asked me round window shielding effect. Round window shielding effect, somebody asked that. But the round window shielding effect means what? That basically, if you see carefully, there's a new iPad. Fine. 1 second. Yeah. Just see this video. Just see this video over there. That this is the oval window and round window. Where the step is written is the oval window. Please look at this one. When oval window goes in, round window comes out. It's alternate compression and rarefaction of two windows over there. It is because the oscular system is giving sound energy to the oval window first. Round window is in the rarefaction phase and vice versa. Okay. Now, if ossicles are not there, both window will be hit by the sound energy at the same time. So in this case, if discharge or the graft covers the round window, it will keep some time gap, some time lag, some phase difference between two windows. This will ensure better stimulation of cochlea because stapes acts like a foot plate and compression, rarefaction like that actually leads to movement of the perilymph in the cochlea, and that lead to the movement of the basilar membrane of the cochlea, and that stimulates the organ of Corti, and that actually goes to the 8th nerve via the vestibulocochlear nerve to the auditory cortex area, to the auditory pathway. Now, everyone, any question you have? Any question you have? Any question anyone has? Anyone, any question about any aspect of the case? So basically, laryngoplasty, what is the most commonly used graft for the laryngoplasty is temporalis fascia graft. Very famous question is temporalis fascia graft, why it is the most commonly used graft for Viva. The number one thing is it can be harvested from same incision. Anyway, you are giving the Wild's post-oral incision, same incision can be extended upward to take the graft from the temporalis fascia region. Number two, it has same basal metabolic rate as tympanic membrane. Same basal metabolic rate as tympanic membrane. Number three, there is no morbidity at the donor site. There is no morbidity at the donor site. So these are the three answers of why temporal fascia graft is more commonly used graft. It can be harvested from the same incision. It has same basal metabolic rate, and there's no morbidity at the donor site. Any question anyone has? Any question? Anyone, please tell me in the chat box if everything okay. Please tell me. Okay, very good. Very good. I hope the session was useful for you. I hope it was meant to be the session revising the case presentation, but along with the Viva also. Anything coming to your mind is absolutely okay. I would strongly encourage you, everyone, to come along with me in the wherever you are. I don't know which social media things you use, because the journey is long. This is the first step towards the NEET PG INICT. Let us target INICT. Let's target very good rank in the NEET PG. Think about later on after the final year is over that what we can do with this thing. Now that's my Telegram and the Instagram group. I will be sharing the link of the WhatsApp channel also with the examiners. You know, with the group actually, and that WhatsApp channel is purely for the clinical academic questions around ENT, some multiple choice questions, some revisions of some summary of the tuning fork, some Viva question for your upcoming this thing, and Instagram and Telegram are there. And I'm a member of, I think Rajamendan sir also took the class over here. Am I correct? Please correct me if I'm wrong. The organizers. So if you happen to be there, you know, you can use the doctorals. If you download that app, the first 3-4 days it is actually free for you. You can always cover larynx or pharynx from those videos only. I'm telling you, if you see the QRP video 5.0, QRP quick revision video 5.0, one time you get the whole gist of ENT in approximately 7.5 to 8 hours only. If you want to do that, try that, have a just overall understanding of ENT, like the one we did just now. You just go to the doc NEET PG section and just see the ENT QRP video, quick revision video. And the first 3 days, I think they give free to every subscriber. Why not use that? Why not really use that? Okay. Now somebody asked, how can manage studying all subjects in final year? Yes, please do give attention to the subject in this order. Please understand the IENT should become at the lower bottom. Your prime day should be having medicine, surgery, obstetrics. Then the second part of the day should be, orthopedics, pediatrics, ENT, ophthalmology. This morning time, if you get like free day today, free day, morning time you devote to bigger subject, medicine, surgery, obstetrics, pediatrics, ortho, ENT should be kept at the evening time actually. Because we have to rationalize, and believe me, this kind of approach, if you do these 6-7 subjects properly, you are preparing for your NEET PG, INICT also in a very, very, very big way. I'm telling you, because they're the principal subject asked in NEET PG. This time also, you see, NEET PG was majorly clinical actually. 12 question came out of ENT, and they were all scoreable questions were there actually. It's like that. So let us not look at this final prof Viva only as the final prof Viva or final prof theory paper. Let us look this phase of our life as a milestone to prepare for the ultimate exam of NEET PG INICT also. That's very, very important, because I know the current things bother us. But if you do a lot of hard work for medicine, for surgery, for obstetrics now, believe me, you will be getting much more time to do the multiple choice questions during the internship. So please do not waste any time now. Invest wholeheartedly into these 7 subjects and properly do this subject. Believe me, you will be getting internship posting little tighter sometime, but you do the multiple choice question of the apps and they'll solve the things for you. Okay, fine. The organizers, any word from your side? I will just switch to the screen. Organizers, please.
Good morning, sir. I'm Shivani from GAME, sir. I would like to thank you for the session, sir. It was really useful and amazing, sir. Especially the way you explained concepts such as the round window effect. We have all heard it, but we didn't really know how it actually happens. So that was really nice, sir. And also about the mastoid tenderness, those signs that you mentioned, sir. We have seen the signs everywhere, but usually where we stumble is when they ask which sign appears first. So that was also really useful, sir. And then also the session was useful. Like we came to know where we go wrong in the presentations, like the tuning fork frequencies. We have all heard like which frequency to use, but not why we stumble there. And then also the Rinne's test and Weber's test. The case where Rinne is positive in sensory neural hearing loss, we all just memorized it. But in this session only, I understood why it's actually the same, why it's positive, why it's actually positive. Same level of difference goes down, so the difference remains the same. So that was also really useful, sir. And also during management, the types of tympanoplasties, that was all really nice. And you also mentioned we need to do a pure tone audiometry first. So like we need to start from the basics and then go to the final part, like why to do a PTA and all that. That was all really nice, sir. I'd like to thank you, sir. It was
Thank you very
really
much for thank you very much for the opportunity and GIMS, and you're doing wonderful work. And this is what actually the doctors, medicals should be doing. And I'm really proud of you guys. You're pulling through academic sessions with the team. It's not easy to spare time, and I have been member of a lot of such student groups and activities in my undergrad days. And I can assure you one thing to all organizers: whatever you're doing today will be eventually helping you into your clinical practice later on in your academic life, into your professional life, and your personal life also, because you know how to do multitask and how to do, sometimes, troubleshoot the things also. These kind of things are very, very important. I will encourage everyone, to appreciate the efforts made by the members of the such student bodies, because we need more student bodies like that to take these kind of initiatives so that we can get, otherwise I would have had a lazy Independence Day morning, but you made my day brighter. And I'm really, really happy to be part of such sessions. And I will be looking forward if I can be of help to the students in any other format, whichever the society wants me to be. I'll be delighted to be part of those efforts. And from my side, I would just like to, end the session by saying one thing. Take the final prof theory and practical exam preparation time as a warm-up session for the NEET PG INSCT also, because we are trained to focus on the immediate goals. I understand that, but look at the 9th class student nowadays in Chennai or Madurai or Coimbatore or anywhere. They are preparing for the IIT JEE from the 9th class. They are preparing for 9th class, preparing for 10th class, 11th class, but the ultimate goal is IIT JEE or NEET UG. And if they can do, why can't we do actually? We prepare for medicine. When you do rheumatology, think about the rheumatology relevance for the INSCT paper also, because you can do INSCT. You can do NEET PG wonderful rank. But only thing is, this particular time of your preparation, though it looks like voluminous to you, I understand ENT Optha, I would really encourage you to see one-time videos of the main NEET PG videos. I put a lot of surgical videos also over there for your Viva. In the app only, there are instrument videos also, which instruments are asked, what is the Viva around that instrument also. It is there in the app only, in the operative surgery segment. And, we can make your life easier for those subjects so that you can save your time for the bigger subjects. And I wish you all good luck. I wish you once again, everyone, Happy Independence Day. I wish you that you'll do a lot of hard work. And I pray that your hard work be chosen to be blessed on the exam day. On the Viva, please, please, please be composed. Everybody has got this in mind that we have to know everything in the Viva, and we start fumbling in Viva. It's okay. Examiners also know. Sometimes they ask tough questions. Even if you do not know that, politely say that, sir, it's not coming to my mind at this moment. It's okay sometime, but let the general Viva go properly. Okay, fine. And do not try to show off too much. Do not really say a lot of things in the first go only. Let the examiner ask you some questions after your first sentence is over. That gives the feeling to the examiner that you know a lot of stuff. But if you say a lot of content in the one line only, they are short of questions after that. And then they start nuclear bomb questions. Nuclear bomb questions, they will be like very high-fi questions. So just play it slowly, smartly, with a lot of confidence over there on the Viva. So thank you very much once again, team.
Thank you, sir. Thank you for taking time from your schedule, sir. We'd also like to thank Doc Tutorials for this opportunity, and thank you, Netra, for volunteering for the case presentation.
It's a wonderful case presentation, Netra. You are pretty confident, composed. I really, really appreciate that.
Thank you so much, sir. And I also learned a lot from you, sir. Thank you.
Yeah. Thank you very much. Thank you very much. Good luck, guys.
Thank you, sir.